what we're going to do now is, sorry, just 1 second. Yeah, so because of some changes that have taken place in the Dania hospital, and we just have a bit of an issue with staffing. And also, personally, just with myself, my health, not able to have meetings 3 times a week. So we're going to just cut it down to Thursday mornings. But sometimes we might, if it's okay, we might add an extra one for the week. But basically, what we're going to do is that we're going to cover ECGs 1 week, and then we'll cover X-rays the next. Then we'll cover an emergency department topic after that. And what it'll do is it'll just give those who maybe joined us a bit later a chance to catch up on some of the older stuff. So while we're busy with this, you're more than welcome to unmute your mic and ask a question or raise your hand or whatever you feel would be better, or just put things on the chat and that would be okay. So it's not just me talking to myself. In fact, you're more than welcome to keep your mic unmuted. There was just a bit of noise in somebody's that I muted it. All right. So yeah, let's see if we can start. All right. So as always, whenever we start our ECG, and we're gonna take a bit of time analyzing this one, just so that you guys understand what's going on. As usual, we analyze axis, we analyze rhythm, our P waves, PR intervals, QRSs, PQRS, and the groupings. Then we analyze the rate, then we analyze each zone. Right. So for right now, we have a 47-year-old man presents after a syncopal episode, right, an episode of fainting, and now only reports palpitations. So does anybody have any differentials, or what would be your thoughts, even before you did your ECG? In other words, this patient has just come into you. You are, of course, going to do your ECG, but what would you suspect as a differential? You don't have to speak it out, you can put it on the chat, whatever it is. And yeah, then we can take it from there. Okay. No, it's not a problem if nobody is too good on the differentials. We'll try and figure it out. Right. So when you look at syncope, especially in an emergency department setting, there's a few things that you have to consider. Right. So in other words, why is not enough blood getting to the brain? Okay. So number one, obviously, is cardiac. Right. So cardiac, any sort of arrhythmias, heart blocks, even tachycardia, severe bradycardias, anything like that can cause it. Then you look at the shock syndrome. So hypovolemic, neurogenic, septic, all of those. Cardiogenic shock, any form of shock that lowers your BP can definitely cause a problem. Okay. And cause a syncopal episode. The other thing you look at always, and you must always consider, is a pulmonary embolus, because I think it's about 50% of PE is one of the presenting complaints is a syncopal episode. Okay, and of course you have things like ischemia, direct trauma. You think about your carotids, you think about a ruptured aneurysm. But generally, what happens with those is that you tend to have an episode and it stays like that. You know, it's very rare for the patient to come back. TIAs can also be part of it. So there's quite a bit. But the cardiac thing is what you've always got to consider first, right? And then you go to the less common ones, you know, mild hypoglycemia, vasovagal reactions, things like that. But those are generally diagnosis of exclusion. So in other words, you've looked at everything else and you've considered that it's none of those. So it could be a vasovagal thing. You know, it could be a glycemic problem. And then one of the other differentials that you can get, especially during summer, is heat stroke as well, exertional and non-exertional heat stroke. So those are some of the things that we look at. All right, so now let's get into this ECG. What I'm going to do, you guys just let me know if you can see everything that I'm pointing at. All right, what I'm going to do, I'm just going to try and use the laser pointer from here. All right. So the first thing we need to look at is our axis. Okay, so what type of an axis do we have? So we're going to look at lead 1 and lead AVF. All right, so we see lead 1 pointing up. Let's draw it out. just so that we know that we're doing the right thing. Just get to draw here, sorry. Okay, so let's just draw our grid. So those are our 4 axes, and we'll take lead 1 and lead AVF. All right. So I know that these are small baby steps, but just in case there's anybody who's on the group who hasn't done it before, just so that you can see. So let's have a look. Let's see. Yeah. Okay, Ernesto, you're getting there. That's for sure. Not a problem. We're just going to just take it a bit slower for some who are still catching up. So lead 1, electricity is moving towards lead 1. That's why it's positive. And if anybody here is completely lost as to what we're doing, please go back and watch those videos so that you can see. So in other words, we've got either a normal or a left axis. We definitely don't have an extreme right, and we definitely don't have a right-sided axis. Okay. So to figure out which one we have, we look at lead AVF, which is at the bottom here, and we see a majority pointing down. So that means electricity is moving away from lead AVF. So in other words, electricity can only be in this direction or that direction. We can't have electricity here because then AVF would be positive. And we've already excluded the extreme right axis. So we are left with the left axis deviation. Okay. So to get to the exact axis, then we look for a biphasic, but we're not going to get into all of that right now. Now, the next thing that we need to look at is our rhythm. All right, so let's try and get into our rhythm. It's this now, sorry. Just trying to get the laser point. There we go. All right, so let's analyze our rhythm strip. All right, so here we have our rhythm strip that's there. Let's look for P waves if we can. So we can see a P wave there, you can see a P wave there, you can see a P wave here, 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 here. So there are QRS complexes that are occurring without a P wave. And then we see an occasional P wave from here to there, but the morphology of the P wave is not very good. It's not a very strong P wave. It's a very weak P wave. And we don't really see any exaggerated P waves anyway. So the first thing we know is this is an abnormal rhythm, right? Because we only have P waves every so often. We don't have P waves all the time. And when we do have P waves, 1, 2, 3, 4, 5, they seem to be quite far away from the next QRS complexes. So the PR interval is slightly prolonged in some of them. So we could be dealing with a conduction deficit, that's for sure. Let's look at our QRS complexes themselves. So any idea, are they narrow or are they wide? You can answer on the chat if you want, but to my mind, they look a little bit wide, and the morphology is not very good as well. You can see there's this little hump over here, if you can put it that way. So we've got wide QRS complexes with irregular P waves, and these may be hidden P waves as well. And we can say for sure that the groupings are not regular at all. Okay. When you look at it a bit closely, if we look at the groupings that we do have, for example, here we've got 3 QRS complexes, and then we have a bit of a gap where we can get a bit of a P wave. Here we have 1, 2, 3, 4, and then we get a bit of a P wave. Here again, 1, 2, 3, 4, and a bit of a P wave. 1, 2, 3, bit of a P wave. 1, 2, 3, bit of a P wave. 1, 2, bit of a P wave. So it's an irregular. Yeah, that's correct, Ernesto. It's wide. Almost an RSR pattern. You're quite right. Okay, so we've got this irregular pulse. All right. So there's a few reasons why you get irregular pulses, and the most common is atrial fibrillation. Then you get and especially we've got a tachycardia here because if we look at the rate at its narrowest, it's at about 150 beats per minute. So it is having a tachycardia. So we have to think of the causes of an irregular tachycardia. And the one that comes to your mind first is atrial fibrillation. Okay. The second thing that comes to your mind is atrial flutter. But when we say atrial flutter, we know sometimes it's 3 to 1, 4 to 1, 2 to 1. And if you're a bit lost on that, go back and watch the video on atrial flutter that we did. Now, because so we get something called atrial flutter with variable conduction, right? So that it could be atrial flutter with variable conduction. You get another one called MAT, right, which could be variable conduction. And because we're looking at wide QRS complexes, you have to consider ventricular tachycardia as well. However, ventricular tachycardia doesn't look like, it doesn't have these odd QRS complexes. It tends to just look like vampire's teeth. But if you were to say this was a ventricular tachycardia, it's the only thing that would put me off is the shape, as well as the presence of the occasional P waves. Doesn't really make sense. So what's happening here is that we do have what looks like a conduction abnormality. If I had to put my money on it, I'd look through the rest of the leads as well to see if they give us any clue. And only in lead 3 do we see like this little bit of a jagged line. So an atrial fibrillation is definitely a possibility. Okay, but what we know is that we've got a tachycardia with a conduction abnormality, and we know that it's irregular. So that also takes VTAC kind of out of the question. So it kind of brings us back to one of the causes of a narrow QRS complex with a conduction abnormality. Okay, I hope everybody gets that. And if you don't, I'm sorry. I want me to slow down. Just tell me. I'm a bit out of practice with the lectures at the moment. I have to get back into it. But basically what I'm saying is that we have a pattern of a tachycardia that's irregular. It looks like the QRS complexes, even though they look wide, the thing that may be making them wide is actually a conduction abnormality. So in other words, there's some block that's going on within the ventricles that's causing this, as compared to just a normal wide complex tachycardia, of which you get two common ones, with ventricular tachycardia and Torsades de Pointes, which we covered before as well. All right. So we're really looking at one of the, let's say, the narrow QRS complex causes. So AVF, AV with variable conduction, or MAT with variable conduction, and things like that. All right. Now let's consider each and every group, each and every lead, and let's see what we can find. So let's look at leads 2, 3, and AVF. So does anybody notice anything that you want to talk about in those leads? And then we can see from there. I hope you guys went through the ECG last night, made some notes, thought about what it could be. Okay, see the chat is a bit quiet. Okay, not a problem. It's no problem. Let's take it step by step. If we look at lead 2, number one, we have a left-sided axis, so we expect this to be pointing downwards. We do have these T waves that are occurring from time to time, and we have a bit of T wave flattening in lead 3. And in lead 3, we see this query atrial flutter type pattern. In AVF, it could also be that there may be a bit of a fibrillation, not a flutter pattern. And we continue to see this conduction abnormality that's going through. If we look at 1 and AVL, now actually, if you look at lead 1 looks like a normal narrow complex tachycardia that's irregular. So even based on that, if you would call this an atrial fibrillation, I don't think anybody would argue with you, but it's the others that will maybe lead away from that diagnosis. And when we get to lead AVL, we start seeing again a bit of a widening of the complexes. Okay, we see the QTs, well, it's within normal and then becomes variable. Now, looking at AVR, we can see AVR looks abnormal actually, right? Because AVR is not supposed to have the majority of its conduction going upwards, if I can put it that way. It's supposed to be down, and this is a left-sided axis, meaning electricity is actually moving away from AVR. So there is something going on over here, right? AVR should not be doing that unless there is a conduction abnormality. Okay, or alternatively ischemia, but this may not necessarily be ischemia. Right, let me just hide this here. Okay, so anybody want to venture a guess as to what's happening on leads V1, V2? Hi, Dr. Adi. Hi, guys. I'm so sorry. I'm just in the middle of a presentation. Okay. Sorry about that, guys. Our medical manager and one of the other HODs just burst in without knocking. But anyway, where were we? Okay, so now if you don't know, that's no problem, but this pattern should start reminding you of something, an M-type pattern, especially in V1 and V2. That should start telling you that it should start, let's see who's got an answer. RSR pattern, bunny ears, very good. And Zakir, you might be able to tell us. So the RSR pattern, just move this a bit to the side so you can see your chat as well. The RSR pattern, especially over V1 and V2, which are looking at the septum as well as the right ventricle. Very good, right bundle branch block. All right, so it starts telling you it's a right bundle branch block. And if it's a right bundle branch block, what we first do is we want to see whether it's complete or incomplete. So we count how big it is. So let's start from our first R wave. So from our first R wave, we've got 1, 2, 3, just over 4. All right, where it ends up is just past 4. And let's count it here. We've got 1, 2, 3, 4. So just past 4. Now, why I say 4 small blocks are 120 milliseconds. So if you want to know if it's a complete or an incomplete right bundle branch block, less than 4 blocks, incomplete. Incomplete right bundle branch block. More than 4 blocks, complete right bundle branch block. Okay, and what we see in this one that's quite interesting. Now, remember, once you've got these bundle branch blocks, it makes it difficult to diagnose ischemia because they start moving their STs all over the place, which we'll get to in a second. And in V3, we're also seeing an odd pattern, which we shouldn't be seeing. V3 should not have an RSR pattern. So this tells us one of two things. Number one, either V3 was placed a bit too close to V2, so it's also looking too much at the right ventricle, or alternatively, there's still another conduction abnormality that's going on the anterior part, because this is a very odd pattern. And in this case, I would actually venture to say that there's another conduction block. All right. The reason why I say that is because if we look at V4, which is now the anterior part of the heart, we see this M pattern sort of continuing this RSR pattern. Right. So let's have a look at, let's think it out. Right. So we've got V3 that's sitting there on the front of the heart. What is it seeing? So what it's seeing is that it's seeing electricity coming towards the anterior part of the heart, okay? And then something diverts it away. So it comes towards it, and then it all gets pushed away again. So that means something's blocking movement of electricity to the front of the heart, and it's kind of got to bypass and come back to get to it, all right? So that's what it's kind of showing us here. And the same thing in V4. So in other words, at the anterior part now is going a bit more anterolateral. Electricity comes towards and then gets pushed away and then comes back again, which is more or less what's happening here as well, but it seems to be happening in the anterior part of the heart. So that means the left bundle is also involved. Okay, just remember, that means the left bundle is also involved. And when we look at V5 and V6, we also see this widening, this wide pattern. And this wide pattern that we see, especially when you start seeing this type of conduction abnormality, again leads us to a left bundle branch block. But it's not typical of a left bundle branch block. There's something else that's going on over here. Because a left bundle branch block, all of yours will be nice and wide. There'll be no RSR patterns and things like that. So does anybody want to venture a guess? And if you don't, it's fine. Let me ask another question. Would you send this patient home? Just by show of hands, tell me who says no. You just raise your hand and then just let me know. It's there on your controls for Zoom. Okay, Ernesto wouldn't. Everybody else sending this patient home. Say, sorry, sir, you fainted and we cannot help you. Let us know how it turns out. Thank you, Sanjula, you're right. Wouldn't send this patient home. So, you know, you're 100% right over there. Okay, so let's just see who else, anybody. Yeah, you could start on Klexane if you suspect the AFib. It's not a problem, you know, that's for sure. And nobody would chastise you for it either, you know. So, you know, that's well done. We wouldn't send this patient home because something is happening, all right? Now, in the interest of time, I know all of you guys have work. Let's just go on to the answer, all right? And then we're going to take it further from there, all right? So what we have is atrial flutter, all right, according to them. So this is atrial flutter with a variable AV block. So we had kind of gotten to that. And what it tells us is that the connection on lead 3 was actually not too good. Okay, so that's why it had this bit of a fibrillation type pattern. But if you didn't get to that part, but you recognize that it was one of the 3, you've already done very well. because as Dr. Sanchez says, you're going to start the patient on what you call anticoagulants. The rate is 125. Okay, we worked it out a bit higher. It's not the end of the world if we didn't do an exact measurement. And here we have something that's called a bifascicular block, right? So we're going to talk about fascicles in a little while. So we've got right bundle branch block and the left anterior fascicle block. Now, some of you are going to go, oh my God, what the hell is all of this? And we're going to start talking about it in a second. So in this case, the rhythm is a wide, complex, and irregular. We got to that part. The most concerning entities with this type of rhythm are atrial fibrillation with aberrant conduction. So in other words, a block. Atrial fibrillation with the Wolff-Parkinson's White, but that don't stress about too much. And polymorphic VT, which we also sort of discounted, right? So two less dangerous considerations, atrial flutter with variable block, which what is here, and MAT, which we had also considered, right? Atrial fibrillation with WT and polymorphic are excluded on the basis of an unchanging QRS morphology, which is true. Close attention to the RR intervals within each group beat. Each group of beats shows that the RR interval remains constant. Okay, so what that means is in those little groupings of 3, 4, 3, 2, there wasn't much difference in the RR interval, which may have taken you back to polymorphic VT. Also missed that. And this excludes atrial fibrillation and MAT because they remain the same, which is correct, so leaving the only remaining possibility, atrial flutter with variable block and aberrant conduction. So for those of you who have been with us now for a few months, you can see that we're starting to get into the more detailed ones now, right? So even if you don't get to this exact diagnosis, but you got somewhere close, like atrial fib or atrial flutter, you started treatment and you started to realize there's a block and you're not going to send the patient home, you've already done incredibly well, right? So now we're going to get into LAFB, left anterior fascicle block. What the hell were we talking about? Okay, so what we are talking about is the conduction of electricity throughout the left ventricle, all right? So we've got the AV node, and then the AV node becomes the bundle of His. The bundle of His then gives you a right bundle branch, all right, which is a single branch going through to the right ventricle, and this is the septum that's lying over here. Then we have the left bundle branch, all right? So the left bundle branch then splits into two. You've got your left posterior fascicle and your left anterior fascicle. So what they are saying is that the blockage occurs somewhere here. Now let's delve into that a little bit deeper. We're going to take about 10 minutes and then we'll be done, all right? So I just want to give you guys a taste of what this is, okay? So let's have a look at what happens. So what happens is when you have a left anterior fascicle block, this is where the blockage occurs, in this area. So the only ones that are left, so in other words, electricity is coming here and then it's blocked off. There's no way for it to go here. So this leaves you with only two other conduction mechanisms. You've got the right bundle branch and you've got the left posterior fascicle. Okay. Now, if you guys are not sure, just stop me at any stage and I'll just repeat it again. So what's happening is we've got electricity that's coming in this direction that suddenly gets stopped. The electricity can't disappear. It has to go somewhere. So what happens with the left anterior fascicle block is quite simply that it reroutes itself via the posterior fascicle. Okay, and via the posterior fascicle and via the other smaller nerves that are conducting here, it then shoots itself down in this direction to try and cover for this fascicle that's not working here. So it goes down in this direction, and then once it's finished there, it then passes itself up in a massive fashion through the rest of the left ventricle, because the rest of the left ventricle has got a large number of conducting nerves. So it's using a small amount of nerve power here, the posterior fascicle, a few of the nerves that are running in this direction, and then after that, it picks itself up again and conducts itself through the entire ventricle. Now, I know this sounds complicated, but what we're going to do is let's just break it down a little bit, okay? If anybody has a question, you're welcome to stop me. I don't mind. So the reason why we've superimposed it on a heart, all right? So here we have the AV node, the left bundle branch, the posterior fascicle, and the anterior fascicle. So something's caused damage here, ischemia, most likely, trauma, whatever it may be, all right, has caused damage there. So this is what I'm saying. It kind of shoots back this way. It follows on the left posterior fascicle and then starts to move back down using other conduction pathways that are present in the heart, not necessarily the anterior fascicle branches. It comes here and then tries to follow the rest of the conduction system back up into the left, into the rest of the ventricle. So in other words, what you are seeing is electricity now coming, moving back, moving there, and then moving all the way up here again. And this is what gives us our typical patterns that we see. That pattern that we are seeing of moving towards, if we had to imagine the anterior part of the heart, moving towards, moving away, moving towards, and then moving away again. So there's a right bundle branch block we've covered already. And now I hope you have a bit of an understanding on the left anterior fascicle. But let's just figure it out in one more slide, right? So what we're going to do in this, we're going to imagine that we are lead one, right? So lead one is watching electricity coming towards it, all right? And then what it sees is that it sees electricity slowly but surely come a little bit towards it and then move away from it and then come back to it in a very big fashion. So what it has is that it has it's supposed to be an SR. I'll just confirm now, but it's supposed to be an SR conduction wave. All right. Sorry, yeah. Am I remembering? No, QR. What am I saying? It's supposed to be a small Q followed by a big R. All right. So because it's seeing a little bit of electricity moving away and then a lot of electricity coming towards it, so it sees a Q pattern first and then an R pattern. And then we look at lead 3. So lead 3 is going to see the complete opposite. In other words, what it's going to see is it's going to see a little R coming towards it and then a big S wave moving away from it. Okay. Now, this is the type of thing I would expect. Hello? I could hear someone there. You're welcome to stop me and talk. Dr. Alvarez, was that you? Okay. All right. So the thing is, yeah, can hear you. Okay. All right. Might just be a bit of background noise. Okay. So like I say, if we imagine ourselves as lead 3, which sits here on the heart, it then sees a little bit of electricity coming towards it and a whole lot of electricity going away from it. So it should see an RS pattern, and whereas the lead 1 should see a QR pattern. Okay. Now, it's something that you've got to try and learn, right? And it's something that if you notice it, you should start thinking, okay, what's going on? So let's see if our patient had all of these. We have a left axis deviation of at least 45 degrees, which means it's a big one, but don't worry about the degrees for now. We had a left axis deviation. The presence of a QR complex in lead 1, all right, which is what we are talking about now. So Q, electricity moving away and then suddenly coming towards it, like what we saw there. And in lead 3, a little bit of electricity coming towards and then a large S going away over there. So you can see how they've actually put it. In order to signify a small amount of electricity moving towards, they put a small Q and a large R, and the complete opposite, a small R and a big S, just to show how it works. Okay. So there can be an RS complex in leads 2, 3, and AVF, but we're not going to concentrate on those because they don't happen. Okay, so this is a more typical example of a purely isolated left anterior fascicle block. Now, this is the type of thing that when you do see it, you don't generally see it in isolation, but it can happen. If you don't pick these up, these are quite difficult ones, but it depends on what the patient complains with. If the patient complains of an ischemic type pain and then you miss it, it is a bit of a problem. But these are the types of patients that most likely may have other signs. This one here is just purely a left anterior fascicle block without any ischemia or anything like that. So what we see is the QR complex here. So a little Q and a big R. And in lead 3, which is on the opposite side of the heart, a little R and a big S. All right. So that's what we're trying to see. Now, if it starts tickling your mind that you may have somebody with this little thing that I've put up over here is easy to Google and it gives you the rest of it, all right? So for example, a prolonged R wave peak time in AVL. I don't know, you know, how are you going to remember that after so long? And then increased QRS voltage in the limbs. Now you've got to count each one out. So these are things that you may not remember when you are looking at an ECG later on. But it's a good thing to remember because it is one of the causes of ischemia and something that we miss quite often. Okay. So are there any questions? Because we've kind of come to the end. That's a little joke just to finish off. I'm not sure if anybody has any questions. I know it's a bit of a difficult topic, this one, because, and the sad part is we don't actually see isolated fascicle blocks all that often. We normally see bifascicular blocks, trifascicular blocks, things like that, which we'll get to in time. But I don't want to confuse you even more than this. And like I say, if anybody has a question, even if not now, you can always question me later. It's not a problem. But I hope you guys enjoyed it. And hopefully every Thursday now we will have one of these. So next Thursday, we're going to do one on X-rays. And for those of you who had a look at the ECG last night, compare your answer to what you got now and see maybe, okay, I don't understand certain parts, try and go back. I'm going to repost the link to the Google Drive folder that has everything. And I hope you guys will enjoy it from there. Okay, if there's no questions, I'm going to end the meeting. I just want to thank all of you for joining. I really appreciate it, especially after so many weeks. I really thought we'd have to start from scratch. So I really appreciate all of you guys who attended. And hopefully from next week, Thursday, we'll keep it going. And thanks so much. It's not a problem. Thank you, guys. I really do appreciate it. And yeah, even though we'll be doing less, but it'll give you guys a chance to go back and revise some of the older topics as well, instead of just moving ahead like a steam train and people are getting left behind. Okay, but otherwise, I'll see you guys next week, Thursday. Keep well, enjoy your week. Bye.